Prynawn da a croeso cynnes i chi gyd heddi prynawn 'ma. Good afternoon and a warm welcome to you here this afternoon. And welcome to our Public Health Network Cymru's webinar series. My name is Cerys Priest and I'm a Senior Public Health Practitioner here in the Wider Determinants of Health Unit in Public Health Wales. And I'm delighted to welcome you here today as we take a closer look at the findings from the COVID-informed study. In particular, focusing on our understanding of what vulnerability is, how it was used during the pandemic, and what the implications have been for using it in relation to groups who have been marginalised further during the pandemic. We have two speakers with us today. We have Sergei Shubin, who's a professor in human geography and the director of the Centre of Migration Policy Research at Swansea University, one of the UK's leading centres of migration studies. He leads the Swansea-based, university-based EU-funded COVID-informed project. His interest in migration studies and mobility and inequality have been developed through international research and his teaching experiences in Russia, UK, France, New Zealand and Canada. And I also welcome Diana Beljars, who is a research officer at the Geography Department of Swansea University and currently works full-time on the COVID-informed project. During her PhD at Cardiff University and at her lectureship and research fellowship, both at Swansea University, she further developed her interest in the experience, politics and knowledge construction of ill health and disability. Before we start the presentations, I just want to make you aware that there will be an opportunity to ask questions, and please do so via the chat box, and we'll have some question and answer session after Diana and Sergei have done their presentations. The webinar is being recorded and will be made available on the Public Health Network Cymru's website after the session, so please do forward on to any colleagues that may have not been able to attend today. We also have English and Welsh subtitles are available and they can be used on switching the button. But however, we are aware that sometimes the Welsh generated subtitles can be a bit inaccurate. And if you do experience any technical difficulties, please let us know in the chat box and our team behind the scenes here will do our best to help you. So over to Sergei, who's going to start us off today.
Thank you very much, Cerys. Can you hear me okay? Great. So thank you very much, Cerys, for the lovely introduction, and Jamie for setting things up, and to everyone who made this seminar possible. I'm particularly thankful for the opportunity to speak to Public Health Wales Network as a kind of group of practitioners, people who are involved in issues related to addressing the pandemic in Wales, and for the opportunity to share the results of this EU-funded COVID-informed project, which we developed together with my colleague Diana Beljars and Louise Condon, who is retired from the project but still supports it. So what we want to do today is to perhaps introduce some of the findings of the project, but also kind of raise a series of questions. And the structure of the talk is as follows. Diana, can you please change the slide? So we'll start with a short introduction, and then we're going to focus on three themes. Rethinking inequalities as it is produced through vulnerability. Think about how we can rethink pre-pandemic policies, specifically in the context of inequalities. And lastly, we try to make sense of the pandemic and see how it's been made sense of, and finish with the conclusions. And the aim of this talk is to develop a greater understanding of what vulnerability is, how it's been used during the pandemic, and what are the implications for it being used in a particular way in relation to certain groups who have been marginalized, or kind of very often further marginalized during the pandemic. So what we want to do is to make this talk useful for you in specific ways by focusing on each theme and going through it in kind of three different installments. First, introducing you to some of the existing findings. Secondly, raising a series of questions. And then finally coming up with this sort of suggestions about takeaways you can have from this analysis. And the COVID-informed as a broader project really is set up to kind of link together these broader themes of inequality and vulnerability, because it's a European project. It tries to understand how experience of some groups have been particularly affected across the pandemic, and we compare our findings across Europe with other countries. We're trying to look at the pandemic and pre-pandemic policy documents, and in our case study in particular, we try to look at Wales and the Swansea region. We we'll also introduce the material from the qualitative work we did with the public health officials, healthcare workers, and civic society organizations. So the interviews we conducted over the period of the last year or so. And we are particularly interested in the certain groups, such as women and BAMI people, the people of Black and ethnic minority people groups, looking at the intersectional lens, trying to bring the different characteristics together. And lastly, we are really curious in terms of vulnerability. We really want to focus on vulnerability as a key concept, trying to unpack different understandings of vulnerability and see how it's been used to different effects in the pandemic policy. So we bring together policy analysis, qualitative interview data, and survey data. And I'll pass it to Diana to continue.
Thank you, Sergey. So I will be talking a little bit more about the theme 1 before I give it back to Sergey for theme 2, and then I'll take over for theme 3 and also the conclusions of the talk. So to think more about vulnerability, everybody has kind of heard more about vulnerability. It has been kind of one of the key concepts that have guided and kind of trailed throughout the pandemic in all kinds of media perspectives and policies and how we talk to each other, what we see as perhaps a threat in the pandemic, and how to express danger and perhaps kind of suffering and misfortune within the pandemic. So vulnerability has been a concept that has a long kind of academic history. Aside from the pandemic, it's used in all kinds of social studies, and it's kind of created as a kind of container concept in which lots of different takes can say something about how social aggregations work, so how social groups function within society or don't function in society, and how marginalization processes work, as well as how inequities come into existence. So what we've been doing is really kind of looking at vulnerability as the key concept in which we can say something about inequities, especially in Wales. And what we found is how these different understandings have some sort of bearing on what happens within society and what happens with different groups in particular. So these different ideas can be kind of condensed in certain or in a couple of approaches. So one is which is the major one, which is something that came up during all the interviews and that we've seen in multiple pandemic policies, which is something that Sergey will elaborate further on. So, for instance, so vulnerability is often denoted as a lack of possibilities, a lack of capacity, of ability, as a sort of kind of an expression of weakness, something that makes people not as strong, not as capable as other people within society who are deemed more successful. So it's a lack. It's something that needs to be kind of filled up, if you will, in order to be erased. So a hospital doctor that we spoke to who works in the South Wales hospital explains it as such. So I would see two different things as vulnerable here. There's vulnerable from a healthcare perspective. So that's the decisions of things like vaccinations have taken place based on who's more at risk catching COVID and who's more at risk of being seriously unwell because of COVID. But that's just one side of it. I would have to say that people who were vulnerable will also be people in society that maybe don't have the support networks they need, or the homeless, for instance. So she really kind of draws, she very much kind of embodies that idea of that people don't have something and therefore they are vulnerable. So it's a very complex thing, because you also can see here that that she draws on two kinds of vulnerability, two approaches to vulnerability, kind of a clinical one and a kind of social one. So Obviously, we are very familiar also with the vulnerability scale, if you will, so the different groups within the pandemic that have been denoted as particularly vulnerable, you know, of different gradations of age and different gradations of severity of illness and kinds of illnesses, cancer and all kinds of immunosuppressing conditions. But to also yes, so it's a complex thing, and this kind of lack, this idea of vulnerability as lack, has been echoed within the City and County of Swansea's strategic equality plan. This precedes the pandemic, but it's something that really suggests how the pandemic has been, or how vulnerability has been understood within the context of equality and governance. So the strategic equality plan suggests that vulnerability in terms of lack is a lack of skills, confidence, self-esteem, aspiration, and health. So health is a very important aspect here that we later see on in the pandemic policies. And also, and this is something that government can see as a kind of position in which it kind of inserts itself. Vulnerability is something that can be solved through governance and through positive governance. Something, a lack can be filled, and the government can be seen to fill that gap. So, for instance, sorry. So one of the ways in which this equality plan kind of tries to address this vulnerability is through adding things to groups that have been seen as vulnerable. So they say in their equality plan and in Swansea, feedback from consultation also suggests that we can explore ways in which community cohesion can be increased and the use of other community safety measures to address the problem. So if we increase kind of the confidence, if we give them some funding, then vulnerability can be solved, which is that. However, when we talk to people considering who have worked through Public Health Wales guidance committees, who've worked with vulnerability as a term, as a way of addressing differential suffering, for instance, they also had this position of, well, actually, it might not be a lack, it might also be something else. So a senior Public Health Wales representative discussed in our interview that vulnerability is really kind of a disempowerment, it's a form of disempowerment. She really kind of turns it on its head by saying that vulnerability is something around people who have had power taken away from them. They are disempowered, and it's not from something that they have done. It's because of, but it's because of things that have happened to them. So therefore, when we turn them vulnerable, when we kind of put the label on people as they are vulnerable, this group is vulnerable, and that very much makes it, she thinks, a label that almost establishes some sort of responsibility for that vulnerability. So once you've been deemed vulnerable, then you are there to take you have to take responsibility for it. So vulnerability, as she notices here, can also be seen and has been seen as a sort of distancing from power within society. So in the pandemic, institutional ideas about vulnerability as weakness or lack did not help vaccination efforts, for instance. And we see how this idea of disempowerment really got into a story on, or a situation with Gypsy Roma travelers. So we spoke to an advocacy representative, and she argues that, or she told us that the vaccine efforts didn't really work, even when vans were driven to the sites by Public Health Wales and the vaccination effort, NHS in the bespoke areas. It didn't quite work, and then suddenly there was a possibility to consider to make use of a certain moment that had nothing to do with the Welsh government, with Public Health Wales and the other institutions, but by the group itself. So she says that there was a gentleman who passed away, and she thinks that was when the alarm bells really rang. And to paraphrase what this long quote, they called her. She got in touch with an NHS person, and then they really quickly set up the possibility for vaccination of this group to happen on this site. So they argue, or they set up a bespoke clinic for the Pembrokeshire Gypsy community, and suddenly, instead of the 3 or 4 that they did every day-ish, when there was a van on site, suddenly there was a big group of 90-odd community members that wanted to be vaccinated. So what she tried to explain with this story is that the social contract between the Gypsy Roma traveller community and the Welsh government and the local authorities, as living separately and not really interacting, was broken by the Welsh government and these local authorities in the context of the pandemic. So it's kind of a social contract that is breached. So strategies built on engagement, or strategies of engagement built on vulnerability labels within these authorities, combined with institutional rhythms of the pandemic, of the vaccination efforts and testing efforts, did not meet with community rhythms, and that seemed to have delayed finding earlier possibilities to make sure that this group suffered as little as possible. So the take-home message, the sub-conclusion of this theme, is that you have to be very mindful of historical positions of groups and individuals within power structures. So what is said is always said within these structures, with all these histories, these perhaps even not very nice histories of engagements between disadvantaged communities and the government and governing agencies and bodies. So Sergey will take over for Team 2.
Thank you very much, Diana. So what we kind of then trying to switch to is to explore how the pre-pandemic policies used vulnerability to address certain inequalities, how this was framed. And you can see the examples of some of the pre-pandemic policies which we looked at. And what was really obvious for us when we did the analysis of policy documents is that quite a lot of them focused on numerical logic. So really trying to think about pandemic, anticipating the pandemic at the time. So for example, exercise Cygnus, which was done by Welsh government together with the UK government, they were trying to anticipate a pandemic which would produce difference in degree, which will kind of exacerbate the conditions of people, but numerically, thinking about more illness, potentially more death, more disruption, more financial logic. So thinking about how current conditions, or conditions which existed before the pandemic started, can get worse in terms of the degree of the pandemic. And we've seen this kind of response from the policies later on as well, in terms of how they, all these graphs showing us, especially in the very beginning of the pandemic, how the deaths were increasing day by day, how the number of affected people were increasing, kind of following from that original logic. And many of these documents specifically use the language of risk, which again can be quantified. So pre-pandemic planning was focusing on trying to extrapolate what we knew about the pandemic, particularly focusing on the SARS pandemic, which hit us in the early 2000s. An extrapolation of the lessons from the SARS pandemic, of the known effects of the pandemic, into sort of a new area. So what would we do if a bigger pandemic strikes? How do we sort of get the necessary data? Once we know more, it was assumed, we can prevent the risks. And the problem with this is that these plans didn't really try to anticipate difference in kind. So they're looking at difference in degree, how the situation can get worsened, but didn't really try to anticipate how we can come across a completely different kind of event, a very different beast, very different disaster. And we therefore struggled, based on these documents, to anticipate and communicate the newness of COVID-19 pandemic in understandable terms. Obviously, we didn't know what is going to hit us in 2020, and it's not strange that there was such a confusion about it. But without this knowledge, without this preparedness for newness, for something completely different, it was very difficult to think about how the pandemic would affect the way in which we live, the way in which we relate to other people, the way different bodies relate to each other. I mean, it was probably impossible to anticipate and answer the questions about how living in pandemic feels, how it affects people. And therefore, it was really difficult to think about the multiple manifestations of the virus and the ways of governing this, the ways of responding to it through the government and healthcare resources. So these plans, as the plans demonstrate, it was pre-pandemic planning was trying to anticipate virus within the existing frameworks of governance, within the existing systems, if you want. And what was kind of geared towards is thinking about how do we deal with the familiar sort of measurements, something like hospital bed occupations, ICU occupations, waiting times in the accident emergency, and so on. So the response was therefore allocating more of the same, more resources, more labor, more committees, and so on. And as within this context, vulnerability itself was seen, very much as as something which relates to risk. And as a quote from the Public Health Wales on a different slide suggests, the word vulnerability actually kind of dropped out from the discourse. This person tells us it wouldn't be a word that we used, vulnerability, but it's all about the data and where the cases are. So there might be certain areas at times that would have been more at risk. It was more about risk, this person says, and high risk settings and how to kind of mitigate that. So what we see here is an attempt to kind of extricate risk and specifically create what the public policy saw as the vulnerable individual, as something which is an autonomous, coherent entity, something which can be taken away and sort of then addressed as a part of this response to the pandemic. But what we also see from the pre-pandemic policy is that they were not specifically targeting equity. In fact, one of the most common phrases we heard throughout the pandemic was, "We are all in this together." That assumption that we all been a part of, we all experiencing the pandemic, we're all going through it, we're kind of responding to it together. But equality wasn't necessarily something which factored in pre-pandemic preparation. And the virus as such was not really considered as something which would affect people perhaps differently. The virus has a very strange thing. It kind of acts. It doesn't discriminate according to in itself. It affects everyone. It's just the effects of it are different depending on people's conditions or different socioeconomic situations. But the virus itself, as we discovered, affects everyone, and people might live with it through a long period of time. But at that stage, the pre-pandemic policies really tried to frame this equality in terms of protected characteristics, as the Wales Fair Report 2018 suggests, or describing vulnerability as a kind of a risk of multiple disadvantage. Policies were trying to divide up people into more or less vulnerable categories, and therefore assuming that more vulnerable people would need more help, more support. And that the different council documents which we looked at also talked about the vulnerability reduction, assuming that effectively it is possible to reduce vulnerability of particular individuals if these individuals manage to fit within the existing policy structures, and if these individuals act in a certain way to make these policies work. Pre-pandemic policies very often were enacted in this very strong assumptions about morality or normativity. You know, if people are not willing to come forward, if they're showing this kind of lack, as Diana described earlier, of engagement or a lack of capacity or this sort of some sort of inability to engage with existing documents, that's their kind of problem. And it was often framed in terms of discussions of barriers to engagement. So there were resources which were not sufficient to reach specific individuals, where vulnerability was seen as inaction, and the virus therefore was seen as something which can be framed as a, you know, as a singular entity, something which can be sort of crystallized. Then the measures against it can be anticipated in a certain way. So virus, as soon as we understand it, can be reacted upon. The measures, anti-measures can be developed, and therefore these measures will target all the variety of people who are in it together, and they will all sort of benefit from this measure. So as we discovered later during COVID-19 pandemic itself, virus is not a singular thing. Virus is a very changeable, unpredictable kind of phenomenon, if you want. It presents itself in a very different forms. So we discovered the things like long COVID, and also different variants. So it appeared, manifested itself in different shapes. So thinking about therefore pre-pandemic policies as something which would deal with the virus as a singular thing was really flawed, because we didn't know and probably didn't anticipate that it's going to be so changeable, and therefore it's going to, even in itself, virus is going to affect different people differently, and it's multiple forms, that different manifestations, this different virus would actually resist the efforts to control it or govern it. We've seen this, reactions from different governments in terms of, fire breaks or quickly imposed limitations on travel, just trying to sort of somehow limit the spread of the virus, which wasn't always useful. So this understanding of the virus, therefore, it reflects the fact that the policies are effectively struggling to correspond to the multiple unpredictable events like COVID. However much we plan, these events disrupt what we know about identity. So we assume that people have different characteristics, and therefore we can find the ways of addressing their specific issues, because we don't know what the pandemic is and how it's going to develop. We really struggle to bring to knowledge the virus and its very complex and differential effects. So instead, we're thinking it's interesting for us to kind of ask critical questions about how these pre-pandemic policies can respond and help us to understand better the potential responses to pandemic. They made us question about what is good and bad, what is on time. So thinking about different temporalities of it. What is on time and what is too late or too early? There was lots of statements about people dying too early, and what is the right place or the wrong place? What is considered to be efficient and for whom? Because very often the pre-pandemic policies were defined and designed with the aim of being efficient. What we discovered later, they were efficient differently for different categories of people. How do we consider what is it too many, too few changes in different times of pandemic? How do we even define what is acceptable level of death? So if you follow this numerical logic, what is acceptable and what can be prioritized, and how do we attach value to different actions? So the existing institutions really struggled with these kind of monumental tasks of responding to the pandemic, and many were just not prepared for it. So what we really want to take away from this, and on the next slide, is kind of a series of potential responses, sort of suggesting that we really have to think about the fact that we can never prepare for an event like COVID. We can think about it, we can plan for it, but it's we need to be open to the potentially multiple changeable manifestations of the virus. That means that the policies have to be, which prepare us for the pandemic, take lessons from the pandemic, from the COVID-19 in particular, have to be less determinate. So we need to think about the ways in which we are less prescribed by previous knowledge and previous experiences of the pandemic, and think about how we can be more anticipatory. And in that sense, we need to think about how we can be anticipatory to new things. How can we prepare? It's really difficult. How can we expect things which we don't know? How do we embrace uncertainty? To what extent we can do things? And one of the responses here is potentially thinking about experimentation. And I know that quite a few of you who are involved in public health Wales and responses to the pandemic, probably in some stages in the pandemic were trying to experiment with different responses to it and think about what works, what doesn't. You know, Diana's example earlier about the response to the gypsy travelers shows that kind of learning curve, how people were trying to think about openness and a possibility to respond to unexpected actions. It's about more rather than having a very prescribed script, very prescribed kind of itinerary of tasks and goals, more or less kind of as a playlist, something which we can attach, change, modify depending on different stages of pandemic and different experience of the virus. Thank you. It's next to Diana.
Thank you, Sergey. So this last theme, how to make sense of the pandemic and how sense is made differently of the pandemic, kind of builds on that. So if we look at how we can understand how vulnerability kind of configures how groups of people respond to regulations, to different kinds of restrictions or protective measures. It kind of has to do with how they understand what the pandemic is. So in the beginning, we had a very kind of perhaps a very narrow understanding of what the pandemic is. We knew vaguely that it was about a virus, that it might be through touch, it might be through airborne transmission. You might die of it, you might get ill, you probably cough. So a very kind of narrow understanding. This is the pandemic. It means that we need to stay home. But now we're further on in the pandemic. It has changed so much, and it's become so much more complex. So when we asked, or when our colleagues at the Swansea Bay University Health Board asked different people of different ethnicity, kind of an understanding of how the pandemic is understood now very differently through different eyes, so through traditionally kind of marginalized communities. So if you see that the most left two categories, old age and pre-existing medical conditions, there's quite some difference in how people see that is the expression, the most important expression of what vulnerability is within the pandemic. So you see that Black people, for instance, are most strongly aligned to this clinical understanding of that this is where people are vulnerable are because. And perhaps you see that white people, so the yellow beams are lowest basically on average, so they would align slightly less with that clinical understanding of vulnerability. Whilst if you swap your eyes to the right of the screen, social isolation and mental health or mental illness is something that was deemed much more important for white people. Asian people put more of an on average kind of pressure and emphasis on low income and living conditions. And then we see Bangladeshi people to be strongly a proponent of thinking that vulnerability comes from ignoring pandemic guidelines. So there's very different understandings of what makes people vulnerable in the pandemic. we go. And as I said, throughout the pandemic, this with time passing, what people thought it was the pandemic is now something different. And this is very much noticed, especially by healthcare workers, which will probably be very recognizable for many of you. So this is we spoke to a midwife manager who worked in South Wales. So she really noticed the difference from when she was in a nurse uniform and in a public place, whereas back then and also now. So she says that the clapping in the beginning was something that was very much something that that kind of manifested how people saw the pandemic, that the clinical people working on hospitals, keeping people from dying in these clinical settings. And she says that people definitely treated me differently. And she remarks that, which is a couple of months ago, it's almost, at the moment, it's almost becoming a norm, really, or a lot of people think that because they think it's gone, you know, so because it's not so much more at the forefront of everything. So it's become this kind of more of an amorphous blob almost. So responding to something, to the pandemic, is then also a lot more difficult. So there are loads of kind of conflicting sides to what the pandemic is. On one hand, you can die from just going to a cafe, but on the other hand, you need to keep your mental health up, which might express in having to go to a cafe, it's seeing some friends. So especially what Sergey brought up earlier, in the beginning, we had some numbers, the first people dying, the first 100 people dying, the first 1,000 people dying, and it was, and our kind of ideas and limits were stretched to, is this acceptable, is this acceptable, and it's just been stretching, and now it's what is enough, or what is too many. It's really difficult to get to really determine something, because there's no benchmark to it. And this also gets at how in the beginning measures were very clinical driven. They were very much based on how to keep bodies apart, how to keep the virus out of certain bodies that had these especially those clinical pre-existing medical conditions. So a Public Health Wales representative argued that she was kind of uncomfortable with giving those very strong clinical and biomedical regulations, whereas she saw that the human side of things was kind of missing and got lost a little bit sometimes. So this was, for instance, when she had to say that in care home facilities that had a positive case, people could not even go to the window to visit their relative who was in that care home. So there are different kinds of pandemics going on over here. There's this whole pandemic, this very social pandemic, and now that everything has become kind of complicated, has become kind of oppositional. We don't know what's good anymore, what's acceptable anymore. Is 1 in 30 people ill at the moment too many? Is it not? Should I go out? Should I not? That's becoming a real problem. So we need to move from this primarily biomedical and clinical knowledge system of what the pandemic is and how we communicate about it to a more social cultural one. So medical clinical knowledge is encompass the kind of the interaction of what bodies do and how the virus kind of mediates this destructive kind of relation between bodies. But it's all about illness and death, and obviously clinical understandings of death and illness are one thing, but it's a much more broader theme for within the social and cultural realm of what it means to be ill, what it means to die, and that is very different for different cultural groups as well. So we need to understand how we can use that in order to understand, in order to stop accelerating and to stop these kind of continuing inequities between groups and differential effects of being infected with the virus. And I'm conscious of time, so I'm going to move to the conclusions in a bit. But the take-home message for this is to shift to social prescription of surviving the pandemic instead of primarily clinical prescription. Instead of utilizing this knowledge pattern of the clinical knowledge pattern of the virus and the pandemic as being kind of encompassing enough to govern it, we need to use the social and cultural knowledges with it to kind of create a new system of regulations or a basis on which regulations can emerge from to kind of counter inequities. So in conclusion, the pandemic has been considered and communicated about in perhaps two material, rigid and narrow ways that may have been more normative than intended and have been received in many ways that have not been understood by the authorities in ways that were helpful and which may have led to exacerbation of inequities, social inequities, and so forth. However, it's clear that resulting depictions are not encompassing enough to understand how social difference, especially in relation to societal groups, kind of differential vicinity to power, produces different compliance. So building on existing social governance structures in which social groups are already marginalized, reproduce views of those in power through those very narrow kind of pandemic narratives, and that will exacerbate those the social marginalizations. So we need to move away from that. Ultimately, what we need is perhaps an extension of a deep empathy towards the other that goes beyond their person and includes their circumstances and social cultural circumstances and histories, especially in relation to power and different centers of power that institutions hold within a Welsh society, and combined with the thought that the people you meet or manage will think differently about the pandemic and different aspects of the pandemic, including vaccinations. So the take-home message is then ultimately we need to move from an understanding of the pandemic being about kind of material, biological bodies that make up populations, and populations that are known through increasing and decreasing numbers. So this is the degree form, to a multifaceted to an understanding of the pandemic as being about multifaceted human beings that make up society that is known through different intensities of hopes, fears, joys, and grief. Thank you.
Thank you very much, both Diana and Sergey, for that really interesting talk through, and I really enjoyed how you structured that, and I'm looking forward very much to reading the full findings when they come out. And it's nice to see qualitative research in action along with a deep dive, if you like, into the policy analysis. So that's been really interesting to me. So if anybody's got any questions, please do pop them in the chat. But one question I do have for both of you is in terms of, this is an EU project, so are there similar studies on the theme of vulnerability happening elsewhere in the EU that you'd be able to share with us, and any kind of early findings from other countries?
Do you answer it, Diana?
Okay. Yes. Well, we've been running reading groups on vulnerability lectures and literatures with partners and within the project and outside the project as well. But we have been the most critical one, the most conceptual and theoretical one. So we've dove in most, I would say, into the conceptual understandings of vulnerability, but whereas the consortium kind of started as vulnerability as very much tied to identities, it is now moving more towards, we need to understand more the processes that make certain people vulnerable, and we need to establish a system in which we can identify those processes. So that's what we've been doing. And that has been spread throughout the consortium partners in different countries in Europe. Sergey, if you want to add something.
Yeah. We've been talking to colleagues in Austria and Netherlands in particular, trying to think about their understanding of vulnerability, and they did work with different categories of people. For example, migrants come into these countries, and yeah, it was really interesting to see that for many of them, they saw that the policies which existed pre-pandemic tended to think about vulnerability in very similar terms to the Welsh policies, simply because it was impossible to anticipate what's going to happen, but also because the very formulation of inequality in these policies was very much limited to this kind of characteristics of people, and it's so that they prompted certain responses to it, which we often not kind of reproduce these categorizations, which caused more trouble, which presented more difficulties. So that was really interesting to observe that the very policies, fair policies, which were put in place to stop further marginalization of people, actually in the pandemic worked against that goal, which is tragic for some of the groups.
Yeah, and absolutely, even pre-COVID, we could have probably shone a light and predicted which groups were going to be most affected, and sadly that was, very much the case. But obviously it's pertinent in the news now. We're at the start of a new wave, and we're 2.5 years in. I think we've all lost track of how long we've been in the world of COVID pandemic. But it was great that you kind of had some lessons learned and things for people to kind of take forward. But yeah, what are some of the challenges, do you think, in implementing some of these actions when it is still very much a changing and evolving situation? I don't know if Sergey or Dana got any reflections.
Sorry, I was reading the comments in the chat, but sorry, I got distracted. So you were talking about the challenges which we learned from the pandemic?
Yeah, as it's still evolving still, and further variants and waves.
Well, one of this is really that thing, strangely, that the virus, which is at the center of the pandemic, we talked about with Diana on many occasions, is actually not present in the documents. So what we really see is the COVID pandemic without the COVID itself. So very often when we talk about, it assumes that virus affects people on, we're all exposed to it. It's inevitable. We live in a society, we wear masks and so on. But very strangely, it's like almost people are disassociated, taken away from the virus when we kind of think about their positions. That the virus lives its own life. It kind of mutates, it produces these different variants, it produces long COVID, short COVID, all the different forms of things. We still don't know what it is. we still have no understanding of how it's going to stop or how it's going to develop. So that's one of the things that's really puzzling. How can we, we basically took away the very reason for the pandemic from understanding the pandemic responses. We are sort of seem to react to other things. We react to excessive deaths, or we react to NHS pressures, or we react to economic meltdown. We don't react to the virus. We react to something else that the virus created. Virus itself kind of live its own life. And we just basically just have to live with whatever new mutation it causes. So that, for me, that was really strange that we are not, we don't know how to deal with it. And that planning and everything else, how can it go ahead if we don't know what the what the virus is? So it's yeah, I don't know what Diana thinks.
Yeah, I think it. I resonate with what Xanta Bevis said in the chat, that this monitoring is quite helpful to kind of keep kind of the main ideas about what the pandemic is, why it's scary, why we need to take action, why we shouldn't do certain things, why we should do certain things, is quite helpful. Because if you go on the street now, there is no pandemic. It's just invisible. So it's very easy to forget. And I really have to remind myself, because it's not visible, and it's never really been visible other than through these proxies, like Sergey said, like masks and sanitation stations, which is something that people picked up on in the survey as well. That is what made it visible, but otherwise not so much. And then it's really difficult to kind of create a reality in which you need to respond to something that you cannot necessarily see. So these monitoring, these numbers, these are good reminders to understand that we're still in a pandemic, even though many people may have forgotten about it. And I came out of COVID last week, and I had and this is my second COVID illness. I had it 3 months ago as well, the end of March. So I had an idea what it meant to be with the virus, to be ill of the virus, and how to, tend to my body and tend to everything else. And within 3 days, this time, I was kind of recovered. So even when it's at such vicinity, when I'm absolutely merged with it, to put it like that, I still cannot kind of understand what's going on. If that makes sense. Mm-hmm. So it's it's a moving target that keeps shifting and remains irrecognizable.
Absolutely. Before we finish off, I'm just going to read out the comment in the chat bar here, just for the people who are watching back. They won't be able to see the chat bar. So this comment from Xantha, who says, thank you very much and for the presentation, and she feels strangely justified in the pandemic obsession of monitoring, of discussion about the pandemic and people's understanding on social media. But she was hoping, could you just quickly explain on the bar chart that you just showed about expressions of vulnerability, what the question was that people were asked? Just so we can have a further understanding of that. And then she also says she'd been to a lecture on lessons learned from SARS at Oxford Brookes in 2007, and checking her notes. And of course, you guys were right, and there was no reference to vulnerabilities or health inequalities, just something about what to do with pets. So yeah, if you could just answer that question about the bar chart, just so we got a clear view of what participants were asked, that would be great before we round up.
Yes, thank you for that question. The question was, what makes people vulnerable in the pandemic? So really quite open-ended. It was an open-ended answer box as well, so people could just write what they understood as what they thought. No, wait. No, it wasn't open-ended, sorry, but there were suggestions given, these 7 categories or these 8 categories, and you had to rank them. So more points would go to things that were higher on the priority list, and less points were given to items lower on the priority list. So therefore, that creates a kind of difference in the answers, and the chart itself changed it to kind of the percentage, not the absolute numbers. So you could see the difference within the group and between the groups.
Yeah, very, very stark differences as well. So thank you. So we'll wrap up there for today, and what I will ask if Diana and Sergey, you can share your papers and further results as you find them, and we can make sure that we get that out to our network members. But thank you very much both for today, for your time and for the discussion. And if anybody else from the Public Health Network Cymru would like to suggest or indeed contribute to further webinar topics, then please do get in touch with the team. We've got a short evaluation in the chat bar, so please do complete it if you have the time. And that's it. So diolch yn fawr and enjoy the rest of your day. Thanks all.
Thank you very much.
Thank you.
Thank you.